Doctor, the next question would be, all of us here, all our patients, including me, the first treatment we are put on is majority of us is on steroids. Either it is usually during diagnosis we would have been admitted for a week with crippling joint pains, the sort of pains that you can't move, you're just on a bed, and that sort of excruciating pain. And then we are introduced to this magical injection of a steroid injection, and we're given some medication, and suddenly we're able to move our joints, we are able to walk, and it's almost like a miracle. From relatives, we hear from friends, steroids are very dangerous, don't take it. But at the same time, we realize the role, especially when it's prescribed by a rheumatologist and it's done the right way. But in my case specifically, doctor, over the years, after like 3, 4, 5 years of steroid intake, I was diagnosed with osteopenia. And that was a completely alien term. I was made to do something called a DEXA scan to check the bone density, etc. And it came off as a complete shocker and out of the blue. We weren't even aware or sensitized to the fact that something like this can happen. And so what can happen in such situations is we might tend to stop steroids, and patients tend to self-medicate. Where is the healthy balance, doctor? And what is the relation between steroids and bones?
This is a very important point. Like, steroids are sort of essential, but at the same time can be harmful as well. So in a condition like lupus, at times steroids can be life-saving. So, but at the same time, we need to understand that steroids are not always safe. I mean, there are times when steroids can have harmful effects also, like what you have, osteopenia and all that. Basically, steroids are anti-inflammatories, strong anti-inflammatories. It's got a very wide use, while it can have difficult problems, but if a person comes to you with a life-threatening allergy, a steroid can probably save his life. But steroids have a definite issue with the bone. If you, especially long-term steroids, higher dose steroids. So if a person with lupus is taking steroids, we should sort of anticipate musculoskeletal issues like osteopenia. The term that you mentioned actually means that there is a diminished bone strength, which sort of predisposes us to easy fractures, bone pains and all that. So while few years ago it was all clinical, we used to say that, looking at the x-ray, saying that okay, there is osteoporosis, the bone doesn't look too good. But now we can actually do a actual very accurate assessment of how strong the bone is. So that can be done using a technique called the DEXA, the one which you underwent. It is, the expansion is a dual energy X-ray absorptiometry. You don't have to worry about it. It's DEXA. DEXA basically measures the bone strength, how much of bone is there in a unit mass, like it's the quantity of bone divided by the area. And to simplify the whole thing, it actually gives you something called the T-score and a Z-score. If you just look at in the Google about T-score, it is basically a standard deviation, the difference in standard deviation between a healthy young adult with the subject. So if you have a T-score less than minus 2.5, minus 1, between minus 1 and minus 2.5 is osteopenia. That means you have a bone strength loss, but it is not too bad. But if it is less than minus 2.5, like if it is minus 3.5 or minus 4, it means you have osteoporosis. And that actually makes it very important, because a person who has got a T-score less than minus 2.5 might need something more than just calcium. And I would also take this opportunity to to give you this message that when you are anticipated to have some steroids, you should take calcium and vitamin D supplements. That probably will prevent some amount of bone loss. But if your T-score is well below the normal, you might need medicines other than calcium as well. So T-score, the DEXA is very important. I wouldn't say that I would need a DEXA for every single patient, but I might need a DEXA when we anticipate the steroid use to be more than a month or so. We would like to have a DEXA, a baseline DEXA, and probably we'll repeat the DEXA after a few months to make sure that you are not losing too much of bone.
Right, doctor. Doctor, my question would be, how does a patient know that it's time to pay attention to bone? Because how do they differentiate between a bone density pain or a joint pain? And a lot of times these pains and the signs the body is giving you overlap with the other. and that can be very challenging, and then we don't know whom to go to at that point. So how do we distinguish between a bone pain and a joint pain?
Yeah, it is extremely difficult. Like the main issue with osteoporosis is that in many people it is very asymptomatic. I mean, you may not really have any pain, and the first indication that you have a problem is it might be a fracture. You might actually present with a fracture, and then only you start recognizing that there is a osteoporosis. But in general, the lupus arthralgias are usually transient. It doesn't last very long. Many of these pains will be troubling you, but it won't be it won't last very long. But if you have a constant pain at one side, like if you have a back pain or if you have a groin pain, you should think about other reasons, and probably that is the place where an orthopedic surgeon will need to be consulted. So I think osteoporosis as such, to assess it clinically is very difficult. It's very difficult to say that you have osteoporosis just based on a clinical consult. But with the DEXA available, I think if we have a suspicion of osteoporosis, especially when you are on steroids, I think we should use that facility here.
Okay, doctor. Thank you for that.